voice that as a community, they felt and others agreed that we weren't doing a very good job of asking, first of all, about suicide and suicide risk. And when and if we did, it wasn't necessarily standardized. It might be, somebody might be applying the art, and there was a lot of variability. And we knew, or we came to know of an evidence-informed tool, the Columbia Suicide Severity Rating Scale, a screening tool out of Columbia University in New York that was designed to be used by both clinicians but lay people as well. And this really took hold in our group. We thought this was something that we needed as a community. And I felt as a layperson coming into the world of mental health, it can be very overwhelming and complex. And this seemed very simple. And I moonlight as a high school track coach. And for me to do that in the state of North Dakota, I have to be certified in CPR. I'm not a cardiologist, but I'm a layperson who needs to be prepared to respond to a physical health emergency. And the Columbia is the mental health equivalent of that for all of us. And so I want to share with you our community's experience, talk about this tool, and see if there are questions along the way. Dr. Alvin developed this presentation, and I've modified it with his consent, and so this is our hours together. And I think Dr. Faust went over these for educational. Okay. Okay. So we'll jump right into it. So the goals of this community suicide effort are twofold: prevent suicide and suicide attempts, and reduce the burden of unnecessary intervention. So the first one I think is quite obvious. The second one, it took a while before it became so apparent to me, but when we first came to the table, law enforcement and our first responders were prominent in this discussion. And it was common for us to hear things like, you know, if on a call and somebody talks about or refers to self-harm, the default in our community had been that was an automatic trip via ambulance to the emergency room. And that was for a number of reasons. Liability was one. But what we all learned together was that that might not always be the best response. And if we had a tool that could help us discern the appropriate risk, we could maybe do a better job of getting people the appropriate care, using our resources more efficiently, and maybe not re-traumatizing folks that are already in crisis. And so preventing suicide and suicide attempts and reducing the burden of unnecessary intervention. And so as it stands, each of our 3 large metropolitan police departments, our ambulance service, First Link, our mobile mental health units, each of our big public schools, our 2 large health systems, Essentia and Sanford, MSUM in Moorhead and NDSU, PATH, all of our shelters, and the Rape and Abuse Crisis Center are using this tool with their staff. And so it's really gained a foothold in our community. And I'm going to move up just a little background on suicide to start, and then we're going to jump into the tool and devote our time to that. And so the Centers for Disease Control released some information this summer. We know that in 2016, 45,000 people in the US died by suicide, 128 in North Dakota, 683 in Minnesota, that the rates have increased dramatically since 1999 by 40% in Minnesota, 57% in North Dakota. And if you look closely, there's pockets in North Dakota where it's increased at a rate even greater than that. And so that's cause for alarm. We know that in high school age students, that 17% have seriously considered suicide in the past year, 13% made a plan, 8% made 1 or more attempts, and almost 3% needed medical attention. We know that lethality is really important, and that almost 60% of completed suicides are by firearms, and that suicide rates for adolescents are 4 to 10 times higher in homes with a gun. This one particularly applies to this group. 50% of suicide victims see their primary care provider in the month before suicide. 73% of older males. So a real opportunity. And our two health systems in town are taking advantage of that. About 15% see their behavioral health provider in the month before. If you're familiar with the Adverse Childhood Experiences study that looks at the various adversities that can increase risk for unhealthy behavior and chronic disease, things related to neglect, abuse, and family dysfunction. With each increasing adversity, it increases the likelihood of someone ever attempting suicide. And so trauma and the impacts of trauma are important when we're looking at suicide and preventing it. Now, one of the prominent, or maybe the prominent theory in suicidality is this interpersonal psychological theory of suicide. And it really, as I've learned it, it describes a perfect storm of events. First, there needs to be a desire for suicide, and the desire comes from a perception of burdensomeness. Now, this doesn't have to be reality, but if somebody believes that they're a burden to others from maybe that's chronic disease, maybe that's a mental health disorder they have, but a person needs to feel that they're a burden. They also need to feel that they've attempted to connect and belong, and those have been unsuccessful. You know, this might be something as simple as standing outside of church and nobody chooses to shake my hand when they walk out. To me, in my mind, I might feel like I attempted to connect and that effort was thwarted. So those are two pieces that can lead to the desire for suicide. And then we need to acquire the capacity. And as I've learned, we're wired to not harm ourselves and to harm others. And to overcome that wiring, something needs to happen. And that something really looks back at these adverse experiences that we've had. And so if we've had adverse experiences, haven't had appropriate care and treatment and support, that puts us in a position where we're going to be able to we will have acquired the capacity for suicide. And so when we acquire that, and when we develop that desire, that puts us in this position where we're at high risk for suicide completion or serious attempts. And so this is variable. My perceptions might vary from day to day. It might be affected by current circumstances or life experiences, but there are certainly foundational risks that are more static that might be related to me having a chronic disease, things that are variable that bring some fluidity into the assessment and dynamics with suicide attempts. And so let's quickly look at some biopsychosocial factors, and then we'll look at the screening tool itself. And so the big behavioral factors are the biggest predictors: previous attempts or behaviors. That people with previous attempts experience more intense forms of suicidality in the future, and that lifetime ideation with intention to act increases the risk of suicidal behavior 4 to 9 times. So previous attempts and behavior are huge. Cognitive factors, limited reason for living, frequency of thoughts, lack of deterrence, talk of death are contributors. Access to means and opportunity, specificity of plans, and then courage and competence to make an attempt are the cognitive factors that are predictive of attempts. The emotional factors, the emotional consequences of trauma, that we know that more than 90% of patients who attempt suicide have a psychiatric disorder, and that active psychopathology in general increases risk versus a specific illness. Physical factors, certainly chronic disease and chronic pain are two of the big predictors or variables that affect suicidality. And then age, risk of suicide completion increases with age, but younger adults attempt more. And if you think about that for a moment, and the next one, that white men over 85 have the highest suicide rates, you just need to look at suicidality, or the lethality of means to explain those things. Men represent about 80% of all completed suicides. Women, however, attempt 3 times more. And the LGBTQ individuals have higher rates of thoughts and behavior. A couple other notable factors, these might be more the dynamic: failed relationships in the past year, violent behavior, rural living and loneliness that can come from that, lower IQ, discharged from a psychiatric hospital. So then what are those things that are protective factors that help us? And of course, the first one is effective and specific treatment for medical problems, for mental health disorders and substance abuse, which I know it can be challenging sometimes in rural North Dakota. That ready access to clinical care is vital. That limiting access to lethal means, that we know that are protective factors. Strong support from family and community and the medical community, and that having the personal skills to resolve conflict and problems is predictive of resiliency. And then certainly if we look at our faith communities that have cultural norms that do not accept suicide. So that's maybe a quick and dirty background. And so it leads us to the actual use of this screening tool. And what I've learned and what we're using in our community is, there's a link in this presentation that has a 20-minute video, a simple training that anybody can follow to begin to develop the foundation to use this tool. And then one of the predictors of people answering questions honestly is the level of trust that they have with the person who's asking them. I've actually been asked these questions as part of a routine primary care visit with my primary care provider in Fargo. And what I found was the questions were somewhat rote, and they seemed like they were being asked in a manner that maybe wasn't so empathetic, and they were needing to be done. And so I would encourage you, if this is a tool you ultimately choose to use, that how it's used is probably as important as the actual content of the tool. So develop an introduction that's going to ask for permission. And from the folks in our community that use this tool, from the healthcare world to the law enforcement, what I've heard is when somebody asks for permission, that almost without exception, it's granted. And in many, many cases, it's almost like a burden has been taken off the person's shoulders. They were too proud to ask for help, but after asking for permission to ask questions, that this person was relieved and willing to get help. And so, you know, you might ask, we routinely ask people about their risk of suicide. May I ask you some questions? May I ask you a few questions about your thoughts and behaviors in the past few weeks so we can better help? So I think that's an important starting point to getting to the point where we use the tool. And so each of you received this screening tool. And so if you can, if you have that on your screen or the printout, if you can pull that out at this point, and let's look at this. And what you have before you is red, yellow, and orange. This is the screening tool and the triage plan that was developed specifically for Fargo and West Fargo. We have a separate one for Moorhead because some of the providers and some of the services are different. But this is one that, if your community chose to do it, you'd want to create your own. Now, I have it in a full sheet of paper. Our law enforcement in Moorhead, they have shrunk this. They've printed questions 1 through 5 on the front of a quarter page, and question 6 in the triage plan in the back, and they laminate it so they have it in their pocket, so they don't have to have it memorized. And so the tool is 6 questions, and depending on how those questions are answered, we will ask some or all of those. So initially, over the past month, have you wished you were dead or wished you could go to sleep and not wake up? All right, we'll see how they answer yes or no. What I've learned is that there's no increased risk for acting on suicide, regardless of how that first question is answered. And then we'll progress to question number 2. Have you actually had any thoughts of killing yourself? And the answer to that question, that's a general, non-specific thoughts. Just have you ever had any thoughts? And I'm asking this question as it is written. Based on how it's answered, then that'll determine our next step. If we answer no, then we're going to go down to question number 6. Questions 1 through 5 are about thoughts and ideas. Question 6 is about behavior. So we're going to assume I answered no for the first 2. That'll bring me to question 6. Have you ever done anything, started to do anything, or prepared to do anything to end your life? You can see all of the examples of potential actions. And now they have a chance to answer that. If they answer no, that would be low. If they answer yes, then we need to follow up and figure out when have they had these behaviors. If it's been in the last 3 months, that's considered high risk. If it's been between 3 months and a year, that's moderate risk. If it's been more than a year, that's low risk. And so what we would do in this circumstance is we treat the top 5 questions and the bottom one, the 6th one, as separate screeners. And whichever one comes out higher, we take that to the bottom of this page to determine our plan of action. Let's wait on the triage plan for a moment. So we're going back up to question 2. Have you actually had any thoughts of killing yourself? I'm answering yes. So now I'm going on to question 3. Have you been thinking about how you might do this? So does the person endorse thoughts of suicide? And at least one method. If they answer yes, well, regardless, we'll continue. We'll go to question 4. Have you had these thoughts and had some intention of acting on them? So now we're talking about intent. And finally, 5, have you started to work out or worked out the details of how to kill yourself? Do you intend to carry this out? So that's a plan with specificity and intent. And so once we start asking questions 3, we go all the way to 5, and then we look to determine. If they answer yes to question 5, that's high risk. If they answer no, it's moderate. And if they answer yes to 4 and no to 5, it's still high risk. As you can see, yes on question 4 is high risk. And so we would then ask question 6, and again, compare the first 5 questions to the last 6 and choose the one with the highest risk and take it to the bottom of our page. And then on the bottom, yellow is low risk, and our plan is, the first step is, hey, does this person have a connection with a primary care provider or a behavioral health professional? If they do, let's provide a warm handoff. So one of the key things for this being successful is we determine they're low risk. We want a warm handoff. Hey, can we help you make an appointment? Whatever we can do to support them to make sure that this happens. Maybe we're going to put a jog on our calendar to call a week later. Hey, did you get in for your appointment? To make sure that this person did get a chance to see a provider. If they don't have that relationship, First Link, which of course serves our entire state, you can connect them with First Link at 211, and they have a very strong support program that can connect people with resources. They've got a follow-up program where they'll make follow-up calls to make sure somebody's getting care. And so those are the steps that we would consider if somebody was deemed to be at low risk. If you determine they're at moderate risk, well, in Cass County, then we have a number of options. And this isn't the easiest, but we have a human service provider that during weekday hours, they have a response team that can come out. There's a queue. This isn't an emergent response, so we're hoping to improve upon this. But we also have a mobile mental health team that Southeast Human Services contracts with for after hours and weekends, and they have a 20-minute guarantee. And so these are mental health professionals that come out. They actually dispatch mental health practitioners to come out to de-escalate, to help connect with resources. And so these are mental health professionals that can get involved at moderate risk. If we deem it's at high risk, we can still access Southeast, but if we really think it's high risk, that might be a quicker call to the mobile mental health unit to see if we can get them out, or actually calling 911 and activating the emergency response system. So this is what we've determined for our community, and it's seeming to work. Now, there are things that we're continuing to work on with organizations building into their policies systems for training their new staff, having ongoing training for their existing staff, so this can be part of their lifeblood. I know that Essentia Health rolled out the use of their tool in the Fargo-Moorhead market, first with their emergency department for inpatient, and then in their clinic setting. But now they have it built into Epic, their what's the system? Their online, their patient, their medical record. Yeah, on Epic, they're on their medical chart. And it has triggers in it that, based on what they find, there are interventions that will pop up on Epic to help the medical providers to know what path to take. And so that's the quick and dirty about what's happening in Fargo and Moorhead. I will tell you, as somebody who wasn't trained and isn't clinically trained in mental health, the first time I saw this tool, it was a little scary. For me to think that I was going to have to ask somebody, or I might need to ask somebody over the past month, if you wished you were dead or wished you could go to sleep and not wake up, that was pretty hard. It was hard to read until I opened my eyes and thought, well, what are the consequences if I don't ask it? And as a community, we're getting much better about asking it and using this tool to help make sure we get some objective information to get people appropriate care. So with that, I think, can we open it up? Does anybody who's on the call have questions for me about this tool?
While people are thinking about what questions they might want to ask, I just want to make a couple of comments. Part of the reason that we wanted to have Rory present this was because the topic of suicidality does create a great deal of fear in people's minds. And what the data has shown is that some simple structured behaviors can help people in a situation where they may be anxious and have a lot of emotion and fear about a topic. I really liked what Rory just said at the beginning about this is like CPR for mental health. So we were looking for a simple, evidence-based kind of topic and way to discuss this that was reachable for lay people, for primary care, for first responders, so that everybody would be using a standardized methodology. And I would agree with Rory that both the idea of asking these questions can feel a little anxiety producing for people, as well as looking at the screener when you are first introduced to it, there's really no way for it to not look a little bit overwhelming. And I think people have to kind of get used to it. But it's very much like any other screener that we use. There's a 2-item pre-screen, and depending on whether you sort of test positive on that, it gives you guidance about whether you're going to go deeper and ask the 3 through 5 questions. So it's been very helpful to demystify and simplify this, because we know that suicide risk isn't a black and white issue. It isn't an on or off issue. And that there are degrees of suicidality and there are degrees of risk associated with various factors, which I think Rory has outlined for you really well. And the Columbia tool really has done an evidence-based approach to risk stratification, so that if you ask these questions, you can hear, as Rory described it, it walks through ideation, it walks through intent, it walks through planning to help sort of set that up. And as Rory said, if we don't have ways to discriminate between high risk and low risk, our response is always kind of an ambulance run or a panic in the clinic. And we really wanted to be able to help dignify the way that people receive screening and they receive treatment. We wanted to help reduce misuse of resource, because our ambulance folks were having a really difficult time in the metro area with our mental health calls. And so it's helped everyone feel much calmer about what to do in a crisis. So do we have
And I would add, it's helped with communication between ambulance and police and mobile mental health and emergency room, because when one has completed the screener, we don't have to ask that again with the next person and the next and the next. And so it's been really good at helping to provide the next person in line of care with the appropriate information.
I had a conversation recently with someone who had actually had the situation of being asked the Columbia screener. And this is somebody who's had a long history of chronic suicidality and waxing and waning mental health problems. And they told me that they noticed that there's been a shift since the introduction of the use of the Columbia. And the biggest thing that they told me was that I didn't feel like I had to tell my story over and over, because the ambulance people asked me these questions. And then when I got to the emergency room, they already knew what was on my screener. And so they asked me to follow up on those same screens. I will tell you as a mental health professional that one of the things we struggle with a lot is the discrepancy between what gets reported in one setting and then what gets reported in the next setting and what gets reported in the next setting. And this way of standardizing it helps to reduce the discrepancies, because sometimes patients forget, sometimes they're confused, sometimes they get uncomfortable and they want to back away from what was said earlier. And since this is standardized, it helps people to sort of cut through that and actually get a little better clarity about just exactly what people have been thinking. And I think there was a pop-up on the chat that somebody had a question. And I think that person might have been Dr. Schmitz. Dr. Schmitz, do you have a question?
So yeah, thank you. So David Schmitz, family physician on the Project Echo team. I was just thinking through some of the situations I've been in, actually, and I'm aware of in North Dakota, both in the hospital ER situation, but, also in clinic. Sometimes people will be acutely intoxicated, maybe with opioids or with alcohol, with both, or they might be in an uncomfortable physical situation in which perhaps they are in withdrawal. And so they may sort of not be at baseline medically or emotionally, in part because of intoxication or withdrawal. I suppose that wouldn't stop you from using this screener, but I would imagine it might. Maybe I'd want to document that was the condition during which the person was being screened.
Well, we've discussed this extensively in the community, because the initial response was if there was any drug, alcohol involved, that we wouldn't use it. And quickly our folks in the field came back and said, you know what, we need to be able to use our judgment to discern if somebody has the cognitive capacity to answer these questions in their current state. So if somebody's had one beer and they drink a lot, that was the example that was shared, that and outwardly they appear like they could answer it, then they would use it. But it does lose its meaning when somebody's intoxicated or under the influence of a drug, to the extent that they don't have their cognitive capacity.
Although the other thing I would say about that's a really great point, Dave. Part of what the Columbia is it's a here and now risk assessment tool. And so if someone is in a state of intoxication from drugs or alcohol, we know that can certainly increase here and now risk. That's one of the variable dynamic factors that Rory alluded to earlier. And so if somebody's at risk because they're under the influence and their threshold of impulse control is lower, and they screen positive on these things, then that should be taken into account. That's important data about the here and now risk that they have. So I think obviously they have to be cognitively available enough to be able to work with you and to be coherent enough to answer questions. But if they're under the influence and that has increased their risk, that's really important for you to know. It's a great question. Are there other questions? Other people have comments?
Does this seem like a tool that you think could be used in your world, in your environment?
I don't know if they're out there.
This is Chris from Valley Community Health Centers, and yes, certainly we use the PHQ when you get the yes, no, or the scale on the question 9 on the suicide question. So I definitely think this would be a good one to incorporate. We use some other things to sort of get at active suicidality, whether they need more assistance. But I think the biggest takeaway for me today is that there's all the available supports, because I think a lot of people, just like with addiction, are reticent to ask the questions because they don't know what to do when they get the answer they're hoping they're not going to get. And so to hear all the different things, like, okay, you have a suicidal patient that you think needs a higher level of care, it's nice to know there's this integrated system that you could access for First Link or 211 or some of the other things, to not feel like you're all alone and don't know what to do.
Christine, where are you calling? Where are you?
I'm sorry, Grand Forks.
Okay,
Valley
Grand Forks.
Community.
Oh, Valley Community. Okay.
Yeah.
I know that question 9 of the PHQ-9 is used clinically locally as the trigger to use this.
Mm-hmm.
So if that's positive, that's something that will trigger the use of it.
It's a great tool. It's all sort of set up too. I think it's scoring, it's overwhelming to look at, but once you dive into it, I think it's probably pretty easy to score pretty quick. So thank you.
Chris, one of the other things about this that I think is, it's the kind of thing that you can use with a local sphere of influence, and you can make it larger over time. And what I mean by that is that, the work that Rory has done in the community with partners cannot be overstated over the last several years. Because when we first started talking about this, there was huge resistance, because it's not what we do. It's not what, it's changed. People were afraid. And so the group has really worked very diligently to get buy-in from first responders, buy-in from law enforcement, buy-in from universities and campus personnel, and buy-in from hospital groups, so that the sphere of influence and the degree of commonality in using this has gotten larger and larger and larger over time. But it really didn't start out that way. And so one of the things about it that's great is that you can learn to use this within sort of your own locus of control. You can use it in your own clinic. You can develop and practice it so you know what you're going to ask. You can talk about it. You can work in your own clinic to say, well, what are our resources for high risk, medium risk, low risk? What will we do when we run into these kinds of situations? And when we run into a low risk, we can't use the Fargo-Moorhead protocol because we're not Fargo-Moorhead, but what will we do instead? Or what parts of that can we develop? And maybe Rory would want to talk just a minute about the supports that the people at Columbia have available, because they have been incredibly supportive and enthusiastic about assisting in developing kind of larger and larger circles of competence. So,
Christine, we've had on 2 occasions Dr. Kelly Posner, who's the primary researcher who developed this tool, on conference calls. One initially with our law enforcement because they had real concerns about liability, and another with a large public school district here. And she knows what's happening around the country, and so she can share examples about implementation in like environments, and she can address questions that she knows that maybe we haven't had. And so she's a tremendous resource who is way surprisingly accessible, considering this is being used around the world. So if you need, I would say she has made herself very available.
And we can provide the website and the how you access that information. There is a really well-developed website with a lot of stories and information available, and so Julie can send that out after the presentation today as well.
That would be wonderful. Thank you.
Other questions, other comments, disagreements? Okay.
Well, thank you for thinking this was important, for joining in today, and I wish you well as you investigate this and consider its application in your setting. Have a great day.
So we're going to now, I think, move on, and we'll move into the case presentation. Julie, do you want to help me? Is Grant is he on deck and ready to go?
He is on deck and ready to go. Do you just want to stop your screen sharing for us?
Yep, we will do that. You want to stop sharing?
I'm reading.
Nope, you're just not sharing anymore because I'm going to have to leave you this, and you're going to maybe want to be watching how this goes.
Okay, we're ready.
Ready for me?
We're ready.
Okay, so I got a case presentation that I kind of threw together the other day. Like I always say, every buprenorphine patient could be a case presentation. Just a quick note here, looking at our number of participants today appears to be a little down. I'm not sure why that is. If you guys have anybody out there that you think would benefit from this, please invite them, get them in touch with the appropriate people. So it'd be nice to be continually expanding our audience. Anyhow, I have a young male that came to me. He's currently being treated with buprenorphine naloxone for medication-assisted treatment. His history, he was previously in inpatient treatment for both opioids and methamphetamines. He finished that. That was in October of 2016. He did that. At that time, he was started on an MAT program. At some point, too, during his inpatient stay, he had also somehow shared his buprenorphine. I'm not sure what form this is. I'm assuming tablet. I think it'd be kind of hard to cheek a film. Anyhow, that provider at that time, not myself, decided to give him another shot and continue him on the buprenorphine. He was on it for several months afterwards. I'd say 6 to 8 months. Eventually, he tested positive for both meth and buprenorphine, and then that provider at that time had dismissed him from the program. He presented to me. I also treat his significant other with buprenorphine, and she has been really a good patient. She's always on time for her appointments, never asks for refills early, continues to participate in AA, NA meetings and whatnot. And I have 2 or 3 sets of patients that are, husband, wife, or boyfriend, girlfriend that come and see me. It was kind of nice when you can get both of them sober and they have a better overall environment at home to encourage that sobriety and somebody to lean on. So anyhow, I've been working with him now for maybe 5 to 6 weeks, and he is kind of a thorn in my side. He's frequently late for appointments, cancels at the last minute. He's missed some appointments. And we do have a kind of a facility policy on what to do, or as far as how many appointments they missed, and they get a warning letter, and whatnot, and are politely asked to maintain their punctuality and maintain their appointments, because we are busy and there are other people who I imagine would like those appointments. So beyond that, the last time I saw him, or not the last time, the time before, he did admit to taking more of his buprenorphine naloxone than I was prescribing to him. And I've talked to him about the punctuality, missing appointments, canceling appointments at the last minute in the past, and said, basically, this is your last chance. You need to show up to your appointments, show up to them on time. I don't know how many more times his car can start on fire. Once is obviously enough. But so he's been a little better about that, but then he was using his medication more as directed. He said that him and his spouse got in an argument and he was stressed out. So I just said, this is what it is. I believe he's on Zubsolv 8.6, 1 tab twice a day. And I said, you can have 2 tabs a day max. I said, I don't really care how you take them. If, it was a medication that was meant to be prescribed, for once a day dosing, as most of us know that are involved with this, whether it's a mentality thing of an addict or what, they prefer to take it more times a day. Some people also do complain of getting sleepy or groggy if they take it all at one time a day. So I basically told them, I said, I don't care if you take both tabs in the morning, if you take one tab twice a day, or if you take a half a tab 4 times a day. I said, just do not go over that limit of 2 tabs per day. I said, you're not going to get any early fills, and it's just going to get you in more hot water. So Another concern of mine is my affiliation with Heartview Foundation. I heard from some of the staff there that one of their previous patients that must have been an inpatient treatment with him at the same time, he had supposedly tried to break into her house to potentially steal her Suboxone, is what they thought. This was prior to him coming back to me to get back on the MAT program. So some of the staff over there was concerned about me even toying with the fact of restarting him. And I thought, well, if he wants Suboxone that bad, hopefully he's utilizing it as directed, not trying to abuse it. And I thought, well, maybe if I give him an appropriate legal prescription, maybe he won't try to break into houses to get it. So, but he's just, I don't know. He's walking the wire for sure. Basically one more strike, and I think I'm done with him. And I guess I'm just, and maybe I've put up with him longer than some of you would have done. But I'm just, it's kind of one of those cases, there's a lot of background noise. You want to hope that he's trying to do what's best for him. But then you're not sure. I mean, these addicts can be some of the most charming and conning people you'll ever meet. They'll tell you exactly what you need to hear and want to hear. So you have to take everything with them from a grain of salt. So I'm just kind of curious if you guys would put up with this for this long, or if you would have already dismissed him. Like I said, he's one strike away, and I don't have a 3 strikes and you're out type policy, because everybody's different, and for lack of better terms, shit happens. Excuse my language, but that's the way it goes, and these guys are difficult. So I'm gonna give him one more chance, I guess, and I have a feeling it'll be short-lived. But it's, yeah, not everybody is rainbows and unicorns, when you treat them with this stuff. So if anybody has any questions or input on that, I'd be happy to entertain that.
Hey, Grant, it's Chris in Grand Forks. I'm wondering, I didn't hear at the beginning, do you guys call them in for random drug screens and pill counts? Or do you have the capability to do that?
We do, when they sign our consent, the random drug screens are in there. I have not called anybody in at random to do a random drug screen. It's a little difficult, as we're in a very rural area, which I guess also makes us kind of unique, because we see a lot of MAT patients, but only a handful of them actually live, in town here. Most of them are 30 plus miles away. So that does make it a little more difficult, but I do just random urine drug screens whenever they come in. If I'm suspicious, I'll do it. If it's been, 3 months or longer, I'll usually do it. Pill counts, I have that in the contract. I probably haven't utilized it as much as I should, so that would be a good option to look into it to make sure he's utilizing it appropriately, because like I tell him, is with the pill counts, I don't care. They could go to any pharmacy, any clinic, any medical establishment, just ask them to call their pill or count their pills and call it back to me and let me know. Mm-hmm. So that might be an approach I might have to take with him, if I can get a hold of him, if his cell phone didn't burn up in his car fire,
Sure. That's the only other thing is we haven't fired anybody yet. The people, we've just sort of had a few just fall off our radar. But when we get suspicious, that's what we start doing, is just sort of tightening our circle around
sure.
Pill counts and drug screens, just not even with an appointment. We're lucky that we have a nurse that is assigned to track that and do it, so I'm really fortunate. So I can just say, can you put him on the list to call him in?
Absolutely. That's a good idea. And that kind of leads into another good topic, is anybody who's doing this program, how are you guys managing to keep consistent follow-up? Because I am not just a MAT provider. I do lots of things, and I don't have time to just, look over these patients constantly. So when I do my PDMP search, twice a month or whatever, and see how many patients I have, I'll notice from month to month some people fall off. And if I have time, or if I remember, I'll have one of my nurses call them and check up with them and say, hey, what's going on? Do you need help? Are you going to come back? Let me know what's going on. But I mean, do you guys have a better system for this? I mean, how are you keeping track of these people when they fall off the edge of the earth? Does anybody check in with them?
We have an MAT care coordinator, and so she manages all that she's got time during the week. And we only do MAT on certain days of the week. We do it Tuesday, Wednesday morning, and
Okay.
that both the providers are just blocked to do that. And so the patients are scheduled, so we know they're coming in so the prep and the stuff for that. And that's because we just started small and didn't know how else to do it.
Sure, that might be an interesting concept.
Mm-hmm.
Of course,
we're full on those days, so in
Yeah.
terms of productivity in your schedule, you'll still.
Right. Yeah, you try to accommodate people's work schedule because everybody's different. But yeah, so I mean, the good stories are good. Some of the tough ones are tough. But
Mm-hmm.
So Grant, this is Lisa. I was thinking about what you and Chris were just talking about in the comment you made earlier about deceptiveness. That always reminds me of what David Mealy, who is the editor of ASAM, says, that addiction is a cunning and baffling disease. And it can, in fact, be tremendously disheartening and demoralizing to see the extent to which people lie, cheat, and otherwise deceive. And it's hard for providers, I think, because you work really hard to develop a trusting relationship, and it's difficult when people lie to you, and it's difficult to stay away from moral judgment. And I think one of the things I hear you working on here is maintaining your objectivity and giving this individual opportunity as you most realistically can, not giving up on him, but also not giving away the farm in terms of being manipulated. And that's a very difficult balance to walk clinically.
yeah.
And I was just thinking when Chris was asking you the questions about, are you using the tools that you might be able to use in terms of pill counts and urine drug screens? And that made me think about the concept of not working harder than your patient works. You work very hard, and I think that asking them to engage with you in those behaviors that demonstrate they really want to be involved are really important. And so, kind of tightening up the circle of accountability in terms of doing some urine screens, doing some pill counts, and using contingency management. You've obviously had some heart-to-hearts. You've tried to talk to this individual about the behaviors that he's exhibiting that are concerning to you. And so now you're struggling to connect. And so, one of the things that he wants is the medication. And so in sort of the give and the get, he wants the medication, and you can ask for certain things in response to that, which is to stay in connection with you, to do urine drug screens, and to do pill counts. And so you don't have to then be in a position of, yes, I'm going to give it to you, or no, I'm not going to give it to you because you're being a bad patient. You can do contingency management. You can say, I want to engage with you. I want to be helpful to you. I'm concerned that the behaviors you're demonstrating really are manifestations of your addiction reemerging, and that it's driving the bus rather than your effort to be in recovery. So these are recovery behaviors that I need to see you demonstrating in order for us to be aligned together. And I brought up the point about not working harder than the patient, because these are the kind of patients where you feel like you're doing all the work. And it's sometimes helpful to sort of back up and reframe, kind of like Chris just suggested. So I'm going to stop there and see if you have any thoughts about that.
Yeah, no, that's a good idea. And then just as you were talking there, sitting thinking about it, the pill counts, it would be easy enough to execute However, this is another unique situation where his spouse is also on the same thing. And like I said, these are conning people. If he is misusing these medications, if he is selling them to fund another habit that I'm not aware of, he could easily take his wife's meds, bring them in for a pill count in his bottle, and bring them back, and so pull the wool over my eyes.
And one of the things you could do is to sort of, because they're a pair, I mean, you could do the same kind of thing with hers, or you could reduce the size of prescriptions. You know, you could say, I'm on a shorter tether. I can't trust, you know, it's not you I don't trust, it's the addiction I don't trust, but we're going to have to go to shorter prescriptions because I can't really trust, I can't make sense of what you're doing right now. So we're going to reel in the connection a little tighter, and, you know, I'm only going to give you a week's supply, or I'm only going to give you 2 weeks supply. Or, I mean, you have levers you can use here, and you can use the same kinds of levers on the other patient, which is his wife.
Sure.
You have a right to be suspicious, and you have a right to act on your suspicions in terms of recapturing the controls that you have at your disposal.
Okay. Yeah. No, that's good input.
Other people. I don't want to just say, Chris, what do you think about that? I'm curious about whether anybody else has thoughts that they might be able to share in this, or anything they disagree with.
Lisa, this is Dave Schmitz. I just wanted to sort of come off one of the points, maybe a subtle point, but I think having been in rural practice and trying to always think about if there's other things going on contextually, when you do have a pair of folks, and that's not always defined by who's living with whom, or who's a significant other, a partner, or even a friend group, but sometimes when you look at a pairing like this, sometimes I'll make sure that I'm screening in that environment for other issues going on, like domestic violence. It just reminds me of, you know, it's not uncommon that if I see a pregnant woman coming into OB triage over and over and over again, I'll make sure that we're screening for something other than the abdominal pain or the contractions, or, you know, and so in this situation, I just worry a little bit that sometimes people can be manipulative enough, or a subject of the addiction enough, that they may not be so good to the other person, and may the other person may be in some jeopardy we're not aware of.
Well, actually, they've actually both been honest with me. They have had physical alterations in their history, and they've told me basically they've beat each other up in the past. So as of now, they seem to be honest with me, and she's the kind of female who I think probably dishes back as much as he might dish out too, which doesn't make any of them any more innocent than the other one. It's a tough patient population, and not that it should make a difference, but these are a couple of my American Indian clients. It's a different society, a different culture there too.
Which actually speaks to what we've talked about before, and what Rory alluded to today with ACEs and adverse life experience, and what trauma history brings to this. And obviously, you're not making any point about the Native American part. You're making a point about life experiences, and so the chances that they've had adverse life experiences that contribute to their inability to maneuver effectively are pretty likely, and so that is a relevant. Relevant aspect.
I know, just even talking to some of the American Indian. The older generation, I like to talk to them and ask them, what do you see different on the reservations now than you did, 50 years ago? And it's interesting to hear their perspective, and just the lifestyle and the society and the culture that they're brought in is significantly different than, say, where I was raised, 30 miles away from the reservation. It's such a barrier.
The cultural issues are really very relevant.
Yeah. No.
So I want to ask you, I think you've brought us a really difficult case that you're really struggling with. And you made an allusion to that you were feeling a little bit of pressure from your addiction treatment cohort, from your partners on the addiction treatment side. And so I just want to put that on the table because it's real. And so, I think the development of medication-assisted treatment has brought the medical mainstream into the arena of treating individuals with substance use disorders in a way that really hasn't been in the past. And so it brings the addiction treatment community and the medical community into a partnership and a juxtaposition of sort of two different models. And so there's been a lot of difficulty on the addiction treatment side for some folks in developing an acceptance of the use of MAT, because it's, it's the whole crutch thing. And so there's been a lot of great work done helping educate. And I think that our addiction treatment provider partners have come a great distance in terms of understanding the role of medication-assisted treatment. And one of the places I really struggle when I think about this is the whole notion of reducing morbidity and mortality. And so when I listen to stories like this one, I think about the statistics that, somebody who's on MAT has a 50% reduction in mortality at 1 year. And somebody who's on MAT has a doubling of likelihood of the quit rate at 1 year. And that's regardless of whatever else goes on. And so one of the things that's hard is by whatever means necessary, we want to reduce mortality idea up against this is a chaotic person and maybe they're misusing the medication and we're not sure what to do with it and we think they might not be ready and maybe we should sort of, stop doing this. So I think the balance of harm reduction strategies versus helping people get into abstinence-based recovery is a rock and a hard place. Am I right about that?
Yeah, absolutely.
So is there anything that you want to ask, anything you want to say? Are there things that you'd like to hear from maybe the other ECHO team members or people listening to this today? Because it's, I don't know that we all understand what the right answers are yet. I know that we understand there's no single model that has solved any of these problems. And so we have to keep talking and sort of finding our way forward. And I worry sometimes, quite honestly, that folks like you out practicing in rural areas with patients like this maybe don't always feel supported by the recovery community or the treatment community. And that may be, that I may be wrong about that in this particular instance, but I think it is a phenomenon that does happen to people. And I just want to kind of put that on the table and talk about it.
I've had pretty good reception from most of the recovery community and whatnot. Of course, ND treatment, I guess, but then again, I work in both places. I work in the addiction treatment area and I work in the medical side. And actually, that was part of my job description was basically liaison between local facilities to improve relationships and education and understanding of one, what MAT is, of two, what happens at addiction treatment centers, because the communication is not always great. So just a couple of weeks ago, I brought all the local facilities together and we had a meeting over lunch and just kind of had a roundtable and shared what goes on at each facility and what our concerns are. And I think it is really the start to building bridges. So that was helpful.
And when you say the local facilities, are you referring to the local medical facilities?
So yes, our medical center, our nurses, our clinic nurses, our hospital ER nurses, our director of nursing, our providers. I also invited our local pharmacy owner, our pharmacy techs, and then our addiction counselors and our nurses out at the treatment center as well. And then Dr. Hankey was in the area, so she stopped by as well. So we had a good roundtable there. I thought that was very helpful.
Good for you. Others on the call? Anybody who might be able to contribute thoughts to this?
Well, this is David Schmitz again. I'll just say I think this is exactly one of the the purposes of Project ECHO is to help to alleviate some of the feeling of at least being alone in the rock and the hard place decisions. That this is not uncommon, and in my experience with Project ECHO, even in other clinical realms, has really hopefully continued to empower providers to be able to serve our patients the best we can by supporting one another. The other that I think it really brings up is that by asking specific questions about, how do you in a busy practice take the time or more effectively use your time around efforts like coordinating patients that quote unquote have fallen off their appointment schedule or haven't been, how do you coordinate for some of the, I think, appropriate efforts around providing that the pill counts and some of the other efforts. And it does beg the question if there's a way to, again, build a network-wide, whether that's a toolkit or frankly a network of support that supports rural practices in particular. So I know there will be ongoing efforts in the crisis of opioid use disorder and the implementation of MAT, particularly in North Dakota, I think. And so I think bringing up these issues and tough spots actually helps to inform further resourcing to help empower our practices and the providers doing the work. That's the hope.
I just want to pipe in, Grant. This is Rory. I have no medical training, and I admire the work that you're doing, and the effort that you're putting towards this is pretty awesome to see.
Thank you.
So any other thoughts? Anything else that others would say? Anybody want to lay out an opinion about whether Grant should or shouldn't continue engaging with this individual for MAT?
Happy to hear all opinions. Well, I guess that just reinforces that there is no right or wrong answer at this time.
I think that's true. I do have an opinion on this, and I think that the hard thing to do is to walk the tightrope. I think that's what you're doing, and I respect and admire that. I think it's reasonable for you. I hear that you have a trusting relationship to some degree, at least, with both this individual and his wife.
More so his spouse.
And you take what you get, and you use that, I think. And I think the concept of leveraged coercion, you've got something he wants, and you can do some things to help move him in the direction of abstinence behavior. I think that, exerting the controls that you have are important. Not giving up on people is a really important thing. And I think MAT allows us a lot of opportunity to engage with people in ways that we haven't before. And so if you can keep him in dialogue, if you can keep him in conversation, if you can sort of tighten down the rules of the road a little bit and see if he'll engage, it's probably reasonable continuing. If he can't work with you with a little tighter set of controls, that probably will be your indicator that he's not ready right now. The door is never shut entirely. He can come back later. There's always later, hopefully. So you can not think of it in a black and white way. You can kind of sort of move in a little tighter and see if he'll engage with you. And if not, maybe down the road.
Sure.
This just occurred to me too. You've got Heartview and you work there. Like, does he need a higher level of care for a little bit? I guess I forget that because it gets so swarmed in our primary care world, but could you make him do intensive outpatient or inpatient since he's showing these behaviors? And that's
absolutely. Yeah, that could be an option. We had discussed inpatient actually when he had come back to me, and we discussed doing it over again. And he was kind of on the fence. I think at one point he was ready, but they didn't have a bed open, and then he lost it. And so, yeah, but intensive outpatient therapy might be a good option too.
So I think having a conversation with him about readiness, is he really ready to make changes, might be helpful to you.
Mm-hmm.
And that moving him into IOP would be another tool of support if he actually wants to do this. And I think some of the sort of controls of the pill counts and drug screens can help you understand whether he's actually engaged in MAT or if he's engaged in procuring currency to fund something else going on with him. And that will be helpful in terms of sort of fleshing out what's his motivation and what's his motivation level, his dimension 4 ability to readiness for change right now.
Sure, absolutely.
So you can present IOP as an opportunity for him. I don't think we ever make anybody do anything, but it would be a signal of readiness. Does he really want to change? And so that might be helpful.
Yeah. So, and yeah, I know I'm just looking at his chart right now, and on the 28th of August, I screened him, and he was positive for methamphetamine, and he admitted to me before we screened him that he had slipped up, and then I screened him again on 9/18, and he was only positive for buprenorphine. But then I think another underutilized thing too, maybe is actually sending these buprenorphines out for quantitative levels to see, did he just take one before he came in, or is he taking it regularly,
Mm-hmm.
And maybe I'm the one who's underusing it. Maybe other people are better at using it. But.
Well, I think Chris alluded to this, but in the busyness of practice, it is sometimes hard to remember what your tools are.
Mm-hmm.
And so, it's, how often do you screen? What do you screen for? Can you choke down some on how much medicine you give him and the frequency? And I think people will often complain to you that it's unreasonable that you exert more influence. They may complain if you say, well, I'm not willing to give you prescriptions for more than a week at a time or whatever you do. But the alternative is not getting treatment at all. And so that's the sort of leverage coercion part of this. And, look, I really want to work with you. But if your addiction is driving your behavior, then I have to talk to your addiction. And we have to respond to your addiction. And see if we can get that out of the way for helping with your motivation. So I think you want to not feel as if you can't use your tools. That's not mean.
Sure.
It's not unreasonable.
Well, I have to run. I have some clinic patients, so I'm going to have to let you.
So I want to remind everybody. I really want to thank Grant for bringing forward a difficult situation and demonstrating some vulnerability and not knowing the answers. That's always a really hard thing to do. I want to remind everybody to do your post-test, and thank you very much for attending today. Thanks, Grant.
Thank you.
Bye now.
Thank you. Bye-bye.
Thank you.